Welcome dear students. After learning about clinical and audiometric tests of hearing evaluation, in this video let us learn about some special tests. These are more advanced in nature and they are highly sophisticated. So let us learn about all of them one by one. First in our list is recruitment. Recruitment is not exactly the name of the test. It is a phenomenon that is observed in a particular type of hearing loss. In recruitment, there is an abnormal growth of loudness. That is, the patient cannot hear low intensity sounds, but suddenly they begin to hear high intensity sounds as very high to intolerable levels of loudness. Now, a loud sound is heard even louder in the recruiting ear than the normal ear. So it becomes intolerable for the patient. Now typically in colloquial language, I can explain this phenomenon as you must have seen, especially old people who are suffering from sensory neural type of hearing loss. When you are speaking to them in normal voice, they cannot hear you and they ask you to repeat and be louder. And you start speaking loudly and even then they cannot hear, and we gradually keep on increasing the loudness of our voice, and suddenly at a particular volume they say, why are you shouting and why are you screaming? Until then they couldn't hear anything and suddenly it becomes very loud for them. That is because of recruitment phenomenon. And we can use this principle to diagnose, recruit, repeat, and this principle is used in the test. The main concept is a loud sound becomes abnormally loud, unbearably loud in the recruiting ear. Now these patients are poor candidates for hearing aids, because when we put hearing aids, the voice suddenly becomes very loud and it is a disadvantage for the patient. They cannot bear that amount of loudness. Now the test that we do is called as alternate binaural loudness balance test. Alternate binaural loudness balance test. This test can identify recruitment phenomenon. It can detect recruitment in unilateral ear. When there is recruitment only in one ear, this test is useful. How we perform this test? We give a pure tone to the patient. What is pure tone? A single frequency sound, say about 1000 Hertz. And this is given 20 decibels above the threshold of the deaf ear. 20 decibels above the threshold, a frequency of 1000 Hertz sound is given. It is given to both the ears, and let us see what happens. We have the right ear and the left ear. Let us say the right ear is the deaf ear, right ear is the recruiting ear. Initially, say suppose this ear is hearing a sound of 20 decibels. The left ear, the normal ear, can hear that sound at 0 decibels itself. And as we increase the sound, what this can hear at 40, this ear can hear at 20, 60, 40. Like that, a difference of 20 decibels is always maintained. This is normal. What happens in recruitment is, suppose the right ear is the recruiting ear and the left ear is the normal ear. What this ear is able to hear at 20 decibels, the normal ear can hear at 0 decibels. And at 40, 20, 60, suddenly the difference reduces. This ear can hear that sound at 50 decibels. Now we expect the normal ear should hear at 40 decibels. 20 decibels difference is maintained. But the difference comes down. And then at a point, the difference even equalizes. And beyond a point, it actually becomes more. Now here what we observe is, What the normal ear is hearing at 0 decibels, the recruiting ear, the deaf ear, is hearing at 20 decibels. And this difference of 20 decibels reduces gradually, and at a point what the normal ear hears at 50, the deaf ear can hear at 60. And then at one point the sound even equalizes. Later what happens is, the sound the normal ear can hear at 90 decibels, the recruiting ear will feel the same intensity of sound at 80 decibels itself. So in normal hearing loss what happens is, this difference is always maintained. Difference of 20 decibels is always maintained throughout. But in recruitment phenomenon what happens is, the difference comes down. At some point it becomes equal, both the ears can hear equally, and beyond that the recruiting ear will begin to hear the sound as even louder than what it actually is. This phenomenon is called as recruitment, and it is a feature of cochlear deafness. So this test, alternate binaural loudness balance test, can identify the phenomenon of recruitment. So it can distinguish between cochlear lesions and retrocochlear lesions. In sensory neural type of hearing loss, the defect could be either in the cochlea or beyond the cochlea, in the 8th nerve or somewhere in the auditory pathway. Now this phenomenon is observed in cochlear pathology. So this test can distinguish cochlear lesions from retrocochlear lesions. Recruitment is a phenomenon of cochlear hearing loss. So this is our first type of special test. So the main concept of recruitment phenomenon and this test is that the difference of hearing between both the ears is maintained all through at all intensities if it is conductive type of deafness and also neural type of deafness. While in cochlear lesions, partial, complete or over recruitment can also be seen. Partial recruitment is the normal ear at 50 and this is at 60. This is partial recruitment. And when both of them are able to hear equally, it is complete recruitment. And now when the deaf ear is able to hear it even louder than the normal ear, this is over recruitment. So any of these three can happen in cochlear lesions. Now let us move on to the next test in special test category, and that is Short Increment Sensitivity Index. Short Increment Sensitivity Index. In short, it is called as SISI. SISI. The concept of SISI is that patients with a cochlear lesion can hear increase in intensity of sounds in a very sensitive range. Their sensitivity is even better than normal people and also better than people with other types of deafness such as conductive hearing loss or retrocochlear lesions. So how we test this phenomenon is that we take a sound 20 decibels above the threshold of hearing of that patient and continuously present it to the patient for a period of 1 minute. And then every 5 seconds, we increase the sound intensity by 1 decibel. 1 decibel only. Generally in pure tone audiometry, 5 decibels is the interval that is given. But here, suppose I start the test at 40 decibels. I continue by increasing the sound to 41 decibels after 5 seconds. 42 decibels after another 5 seconds. Like that, 20 steps of increase is done. We take a pure tone, 20 decibels above the hearing threshold of the patient, and ask the patient to make a mark whenever the sound intensity increases. So we tell him, every time you hear a louder sound, mark it. Say mark it on a paper or give some signal. And like that we increase the sound intensity by 1 decibel for 20 times. Now a normal person rarely can score beyond 15%. Generally only that much is the sensitivity. That is 20 times if you do. If 20 times is 100%, they cannot even identify 4 or 5 clicks difference. But a patient with cochlear type of hearing loss will score somewhere between 70 to 100%. And a person with nerve deafness, that is 8th nerve lesion, will score somewhere between 0 to 20%. That is, he cannot identify any difference, or even if he identifies only once or twice in that entire 20 decibels range, will he be able to appreciate some change. But a person with cochlear type of hearing loss is very sensitive to these small increments in sound. This is short increment sensitivity index test. So it is diagnostic of cochlear lesions. It is positive in cochlear lesions. This is our second special type of test. The next test is Tone Decay Test. It's called as Threshold Tone Decay Test. The concept of this test is it measures the nerve fatigue. Normally, we can hear the same intensity, same tone sound for a period of 60 seconds. But in nerve fatigue, the person will stop hearing it earlier. Even less than 60 seconds, the person will stop hearing it. So how do we perform this test? We take a pure tone of say 4000 Hertz. We take a pure tone of say 4000 Hertz and above 5 decibels of the hearing threshold of the patient, above 5 decibels of the hearing threshold. For short index sensitivity and for recruitment, we take it 20 decibels above the threshold, but for this test, 5 decibels above the hearing threshold is enough. And we present the sound continuously for a period of 60 seconds, that is 1 minute. And if the patient stops hearing before 60 seconds, then what we do, we increase the intensity of sound until he is able to hear it for 1 whole minute. Or when a point reaches that we cannot increase the intensity of sound anymore, at that point we stop the test. And at whichever point he begins to hear for the whole complete minute, that is called as the number of decibels of decay, and that is the result of this test. Suppose he is able to hear at 40 decibels, then that is the then that is the number of decibels of decay. And anything more than 25 decibels is diagnostic of retrocochlear lesion. Now the first 2 tests were diagnostic of cochlear lesions, and this test diagnoses retrocochlear lesions. So we continue till the patient hears for 1 complete minute, or no level exists above that threshold for which a tone is audible for 1 complete minute. More than 25 decibels of decay is diagnostic of retrocochlear lesion. Next in our list is a test called as Evoked response audiometry. Evoked response audiometry is very important and it is widely performed. It is highly sophisticated. So what happens in evoked responses? Responses are evoked. We give some sound stimuli to the patient and then measure the responses. We are basically measuring the electrical responses in the ear. So, this is an objective test. The advantage of evoked response audiometry is it is an objective test where electrical activity is measured. It requires a specialized equipment and a computer to analyze the signals. And there are various types in which evoked response audiometry is done, but there are two most important tests that are widely performed, and let us see what they are. First one among them is electrocochleography. Electrocochleography. As the name suggests, we are measuring the electrical activity in the cochlea and also 8th cranial nerve. The electrical activity in both of them is measured. So this test measures electrical activity in the cochlea and also 8th cranial nerve in the first 5 milliseconds, that is after giving a sound. The first 5 milliseconds activity is measured in electrocochleography, and the response occurs in the form of cochlear microphonics, summating potentials, and also the action potential of the 8th nerve. We have learnt about these in the physiology of hearing. Cochlear microphonics are produced by the hair cells of cochlea. When potassium inflow is present in the tip of the outer hair cells, some electrical changes, voltage changes occur in those hair cells, and that gives rise to cochlear microphonics. And summating potentials are also produced by the cochlear hair cells, and they are an envelope of the sound stimulus. And usually the summating potential is 1/3 of the cochlear microphonic. Any difference in this ratio is diagnostic, and this is particularly useful in diagnosing Meniere's disease. And this test in adults, it can be performed under local anesthesia, but whereas in children and in uncooperative adults who are very anxious, it can be done under sedation. Sedation does not involve with the result of our test. It does not involve with this procedure. It is important that the patient is not fidgeting while the test is being performed, because otherwise the muscle myogenic potentials will also get recorded into the test. So the patient has to lie still and calm, and the test has to be performed. For that, local anesthesia is enough, or if the adult is very anxious, or if it's a child, general anesthesia can be given. So electrocochleography can be used to find the threshold of hearing in infants and children. And it can also be used to differentiate lesions of cochlea from those of 8th nerve. Because we observe both the electrical activities, we can easily identify if the lesion is in the cochlea or if it is in the 8th nerve. Now the second category in this group is auditory brainstem response. Auditory brainstem response. This test has various names. It's also called as BAER, that is brainstem auditory evoked response, or brainstem auditory evoked potential, or it is also called as brainstem evoked response audiometry. Usually they say BERA, B-E-R-A. BERA means brainstem evoked response audiometry. So they are all one and the same. In this test, what we do is we elicit brainstem responses to auditory stimulations. And how are the auditory stimulations given? By clicks or tone bursts. And this is a non-invasive technique. We find the integrity of the central auditory pathway through the 8th nerve, pons and midbrain. Repeat, pons and midbrain via this test. So this is a non-invasive technique which measures the integrity of the central auditory pathway, that is 8th nerve, pons and midbrain. Any lesion anywhere in these three structures can be identified by BERA. So what we do in this test is electric potentials are generated in response to several click stimuli or tone bursts, and these are picked up from the vertex by surface electrodes. We put surface electrodes on the forehead, on the vertex, and one on the mastoid antrum of both the sides. And these surface electrodes pick up the electrical potentials that are generated. And then a graph is obtained. This test measures the hearing sensitivity in the range of 1000 to 4000 Hz. And when you draw the graph, normally 7 waves are produced in the first 10 milliseconds. 7 waves are produced in the first 10 milliseconds. Now, electrocochleography measures waves in the activity in the first 5 milliseconds. This measures in the first 10 milliseconds, because here we are going beyond the 8th cranial nerve up to pons and midbrain also. So 10 milliseconds is the range. Among these 7 waves, the first wave, third wave and fifth wave are the most stable and they are used for measurements. And out of these also, the fifth wave is most important as it is most stable. And what we get from this test is various parameters like absolute latency. Absolute latency means the time difference from when the click is given and when the wave is seen. That is called as absolute latency. We can also measure interwave latency, that is the difference between two wave peaks. The time duration between the first wave peak and the second wave peak, or between any two such waves. And we can also measure the amplitude of the waves. These can be identified by BERA, and the advantage is that we get the exact anatomic site of lesion. Although there is no complete information as to which wave corresponds to which site, but we do have a broad idea, and let me write that down for you. The first wave, wave 1, corresponds to the distal part of cranial nerve 8. Distal part of the 8th cranial nerve. Wave 2 is the proximal part of this nerve. Then wave 3 corresponds to the cochlear nucleus. We have two cochlear nuclei, the dorsal and ventral cochlear nuclei. Wave 3 corresponds to them. And wave 4, next in the pathway comes. Are you able to remember some mnemonic? Yes. E. coli ma, 8th nerve, cochlear nucleus, O for superior olivary complex. Superior olivary complex. Then L, L for lateral lemniscus. Then the 6th wave and 7th wave, both of them are for inferior colliculus. Now we can use the same mnemonic to remember these waves also, but please understand that the 8th wave, but please understand that the 8th nerve has two waves, one for its proximal part and one for its distal part. So wave 1 and 2, both of them correspond to 8th nerve. Then comes the cochlear nucleus, then comes superior olivary complex, lateral lemniscus, and inferior colliculus also has two waves for it. So there are 7 waves in total. And the uses of ABR are, because this is also an objective test, we do not need the cooperation of the patient or any response from the patient. It is ideal to be performed This test can ideally be performed in infants and children. In infants and children. Because it is hard for them, if they are very small children, say about 2 to 3 years, it's very hard to explain them the principle of pure tone audiometry and tell them if you are able to hear, raise your hand or show something. All those things are difficult to explain to children, and in infants it is impossible. So this test can nicely be used in them because it is absolutely objective in nature. Next, it can also be used in mentally challenged individuals. Such as, say, children of cerebral palsy or some multiple sclerosis patients or low IQ due to any genetic cause. In any of them, this can be used. And another important point is it can be used in malingerers also because they cannot cheat in this test. And this is diagnostic of retrocochlear pathologies. Retrocochlear pathologies. So far, where all have we heard about retrocochlear pathologies? One is the threshold tone decay test and next is this test. This can identify retrocochlear pathologies. Retrocochlear in the sense any lesion beyond the cochlea involving either the 8th nerve or the central auditory pathway. So this test can identify any retrocochlear pathology and it is particularly useful in diagnosing acoustic neuroma, the cerebellopontine angle tumor. It's useful for that. And it can also identify any brainstem pathology also. Can you think of any other test that identifies brainstem pathology? Yes, it is our acoustic reflex test. The stapedial reflex can also identify any brainstem lesion. Another advantage of this test is that suppose a surgery is being performed and we have to identify whether the 8th nerve is functioning or not so as to not damage the 8th nerve in between a surgery. We have to preserve the function of cochlear nerve. Mostly in an acoustic neuroma surgery only this happens. When you are resecting the tumor, we have to preserve the 8th nerve. And how do we know whether the 8th nerve is preserved or not? Intraoperatively we perform BERA. And those signals can also be recorded, and the moment you observe a disturbance in those waves, it is understood that we are going towards the 8th nerve. So it's also useful for intraoperative monitoring of 8th nerve function. Intraoperative monitoring of 8th nerve function. As I earlier told, this test can be performed even in sedated patients. So it's not a problem, even if the patient is anesthetized. So this is about BERA, Brainstem Evoked Response Audiometry. With this I complete Evoked Response Audiometry and the two important tests under this category, electrocochleography and BERA. Next special test is Auditory Steady State Response Test. Auditory Steady State Response. Now this I can say is an improvisation to BERA. BERA has certain disadvantages such as it cannot identify profound hearing loss. That is, if the hearing loss is more than 85 decibels or according to some studies more than 75 decibels also, BERA cannot identify, and to overcome these difficulties we have come up with Auditory Steady State Response Test. In this what is done is, so this is also an electrophysiological test like BERA, but what we do here is steady state signals are used instead of giving sound stimulus. In BERA and electrocochleography, what we do is we give pure tone clicks or bursts and identify those waves. But in auditory steady state response, the steady state sound signals are observed and a graph is plotted. So this is an electrophysiological test that uses Steady state pure tone signals. Steady state pure tone signals instead of the transient signals that are used in para. Here we use the steady state signals. And here also frequency and amplitude can be changed. Intensity of sounds can be changed. And this gives a frequency specific audiogram. So the advantage of auditory steady state response over bara is that it can detect hearing loss that is above 80 decibels also. Now this is very important because we can identify those children who are candidates for cochlear implantation. In profound deafness, cochlear implantation has to be done, and this test can identify those children at an appropriate age. It is even better than bara. So we have learnt about 5 special tests so far. The first test was based on the principle of recruitment. It identified cochlear lesions. Next is our SISI, short Increment Sensitivity Index. This is also diagnostic of cochlear lesions. Next was Threshold Tone Decay Test. This is diagnostic of retrocochlear lesions. Next in the list is Evoked Response Audiometry, that is electrophysiological test. It measures the electrical activity in various parts of the auditory pathway. First is electrocochleography, that measures electrical activity in the cochlea and also the 8th nerve. Next we have brainstem auditory evoked response, that measures the electrical activity right from the 8th nerve up to the midbrain, pons and midbrain also. In that we observe various waves, each corresponding to a particular anatomical site. Next is auditory steady state response, which is even better than bara because it ideally measures profound hearing loss also, which bara cannot measure. The difference between these two tests is auditory steady state response uses steady state pure tone sounds instead of transient sounds. In bara, we give some pure tone clicks for the patient to pick up, whereas auditory measures the steady state sounds. So these are a few special tests. Let us learn more of them in the next video. Thank you.